hopefully you can see my screen here. So Kingman dragged me in to do a third talk here for the year. So I said, okay, what can I do that's a little bit different? So this is a little bit more of a clinical talk, but hopefully an evidence-based clinical talk. And this is a topic, that I feel fairly passionate about. It's good to hear Denise also say she likes this topic a lot. And it's really just this issue about, does the interface matter that we use with when we treat patients with sleep apnea? Is a nasal mask the same as a nasal pillow, the same as a oronasal or full face mask, as some people call it? So no conflicts of interest to declare for CME purposes. Learning objectives are going to be to, understand why oronasal masks were developed in the first place for the treatment of sleep apnea. The second is to describe potential issues in sleep apnea outcomes when using oronasal versus nasal interfaces. And then, third, which I probably should have put first, is really just discuss a real world example, of implications of interface use. And so, like a good clinical grand rounds, I'm going to just start with a motivating clinical case here. So this is a real patient that I took care of, over the last 10 years. But when he first came to me, he was 79 at that time. And he was presenting due to PAP intolerance. And he was initially diagnosed with severe OSA about 10 years prior to that at an outside hospital. And he was treated first with CPAP, and then for unclear reasons was transitioned over to bi-level, And he comes in now because he says, I really don't tolerate the bi-level device. He says the pressure's too high. His wife, who came in, with him during his visit, has noted that, he's very sleepy. He filled out the Epworth. It was 20 out of 24. His wife has also noted just memory issues as well. Outside of that, there were really no significant parts of the medical history other than, one son who I ended up also taking care of eventually having a sleep apnea. He's got class 1 obesity. His SATs were fine at rest, and blood pressure was just a little bit elevated. And the airway was nothing too remarkable to speak of when doing the examination. So, this is the summary of the sleep studies that I had available, at the time after doing a chart autopsy. And, in September of 2009, looks like he had, a split night study at the time. He was found to have 77 episodes an hour. They were all considered to be obstructive events. He was titrated on CPAP and found to require 12. Parenthetical note was that the residual AHI was 12 events per hour. He was brought in November, and I suspect, I don't know for sure, but this is just my interpretation, just because I had the second sleep studies, that I'm assuming they did this because they saw the residual AHI of 12 episodes an hour. And, according to the report, he was titrated on bi-level, settings were up to 23/19. The residual AHI at the level was 1.6. Somewhere a couple of years later, he had another titration study. Looks like there was an attempt to use both CPAP and BiPAP on this particular night. And he was titrated on CPAP up to 20 with a residual AHI of 9.1, was then transitioned over to bi-level for the remainder of the night. And the residual AHI was 1 episode an hour. This is the hypnogram that I had from that study. So you can tell this is an old school study, if you will. But, you can get a sense here, just so if I draw your attention down here to the EPAP and the IPAP, you basically see that up to about 2/3 of the study is really on CPAP, where they get up to 20 centimeters. And you can see that, the predominant event type are hypopneas, which are initially quite frequent at the low pressures and seem to go away, by around 2 in the morning or so. But at the level of 20, the patient was then transitioned over to bi-level for the remainder of the night. There were still some episodes, a few episodes of hypopneas, but not quite as much. You'll note that the patient was in REM sleep for a good part of this night. You can see the oximetry, which is the second line up here, looking better in the second part of the night compared to the first part of the night. This is the a titration table, so looks a little bit busy here, but you can see the various pressure levels. The last 2 rows are the bi-level pressures that were tested. You can see the overall index, here on the far right. So you can see, fairly, significant sleep apnea up until you get around maybe a pressure of around 13 or so. And then you kind of see there's a lot of fluctuation in the overall AHI. And you can sort of see again, the events are, predominantly hypopneas, but there are, sort of a smattering of central apneas and or obstructive apneas that were reportedly scored. This is the gentleman's compliance report, when he came in to see me. Using it in the last 30 days to some extent, but very sleepy as noted. He's using it 70% of the time. However, he's only using it, 4.5 hours across all days, although in the nights he uses, it's about 6 hours a night. And you can see that somehow his bi-level settings got maybe a little bit further tweaked, and he's in spontaneous mode at 20/16. And the residual AHI reported over this period of time is 13. You can also see, just from the leaks themselves, that he's got a fairly high leak at around 74 liters per minute. So, he goes on to say, hey, doc, by the way, I really hate this mask that they gave me. Can you get me one that's more comfortable? To which I kind of say, well, do you happen to have it? Can you show me what you got? And you say, yeah, I got it right here. You say, this is exactly what I got. So he's got this, I think ResMed, I forget what class this is of mask. Is this a Mirage or something different? But it's a full face oronasal mask is what he's been using. So, this raises the question, I think, in my mind, just in terms of thinking about things, are oronasal masks as effective as nasal interfaces in treating obstructive sleep apnea? And what's the evidence base, behind this? And why were these masks developed in the first place? And so why do we think about even using these masks in the first place, right? Who really wants to use something that's going to cover their nose and mouth while they're sleeping at night? So there's a number of different things I think we've told ourselves over the years, or that we've just passed on, from one generation to another. Patients ask for it. This is one of my favorites. Doc, I'm a mouth breather. They're convinced they're always a mouth breather. It's like, well, that's great, but do you know what you're actually doing when you're asleep? And then, kind of the light bulb goes off and people say, I don't really know. Is this just a part of how we're trained? Is that, full face mask should be used if a patient says they're a mouth breather, we should just automatically go to it and not try to push in terms of using a nasal interface. Other times, I'll hear people talk about, other issues like conjunctivitis, skin abrasions, rhinitis, rhinorrhea, dryness, unable to keep a mouth closed. Sometimes it's just our own biases that we think a patient is going to be more comfortable with the oral nasal mask versus a nasal interface. Some patients may have air leaks with nasal interfaces compared to oronasal interfaces, although I often feel that I see more air leaks with full face masks. And sometimes we'll prescribe it because patients have nasal congestion or obstruction. That's probably the one where, I think it may have the biggest role, if you will. And so this is an old study from 1988. This was actually done by one of my mentors. And it was the first study really just looking at the issue of how you measure airway collapsibility in patients in sleep apnea. And so when we make measurements of critical closing pressures in patients with sleep apnea, it's essentially a reverse CPAP titration, where we start at a pressure where we eliminate any signs of airflow obstruction, and we gradually lower the pressure until airflow, linearly goes down until we see periods of frank apneas. And we can then plot what's called a pressure flow curve. And so in this particular study, when they did it two ways. They did it one with a nasal mask, and then they did it once with a full face mask. And what you can see across the 6 patients that they studied is that you see a dashed line in all 6 figures. And those dashed lines are when a nasal mask was used. And you can see that in each of the patients, they were able to determine a critical closing pressure. They were in reverse, they were able to determine an opening pressure as well. However, when they went to using a full face mask, these are those solid lines that you see bordering the x-axis at the bottom. And what they found in this series of patients was that they were unable to open up the airway effectively. And these patients, no matter how they increased the pressure, and they only went up to about a maximum of 10 to, in one case here, up to 16, that the patients continue to have obstructive apneas despite that. And so this is sort of one of the first pieces of evidence of this disconnect, if you will, between the use of a nasal interface and a full face interface. In the early to mid 90s, Mark Sanders and the group from the University of Pittsburgh, published one of the first papers, indicating the success of treating patients with the full face mask. There's another paper published by Rich Berry, which I'll go to next, which was published the same year. But they looked at this issue about, whether you could use a full face mask to treat obstructive sleep apnea. And so in this particular series, they report on 30 patients where they had a successful titration. They don't really talk about the patients where they had unsuccessful titrations. And the oronasal mask was really only offered after patients demonstrated some type of intolerance to the conventional nasal interface. In other words, they had mouth leaks that couldn't be fixed. With the chin strap, for instance, they had significant nasal congestion, couldn't breathe through their nose, or nasal obstruction. Typical population of patients with sleep apnea at that time, high BMI, high AHI. And on the oronasal mask, they demonstrated that there was a resolution of the sleep apnea. 14 out of the 30 patients they deemed required bilevel PAP therapy for one reason or another. And in 2 patients, they used a mouthpiece to keep the mouth open. This still led to improvements in OSA severity. One of the things I think that's really important, because this paper sort of, I think, set the stage for the use of full face masks for PAP titrations. But, even the authors acknowledge in this study, quote, because of the theoretical potential for aspiration of mouth and gastric context, as well as the possible consequences of increased dead space in the event of machine failure when using an oronasal mask, application of positive pressure exclusively via the nose should remain the treatment of choice. This is the study done by Rich Berry and Dr. Preuss, and they performed 2 small sub-studies within this study, where in the first sub-study, they recruited patients with frank nasal obstruction, and they compared nights on full face mask to the baseline nights. And what they found essentially is that, while awake, oral breathing was more often seen than nasal breathing, which makes sense given this degree of nasal obstruction these patients had. And then during sleep, they found that these patients spent about half the time with combined oronasal breathing. And so there was sort of a little bit of, restoration, if you will, to nasal breathing. On the second study, they recruited patients who had acclimated to nasal CPAP and examined the residual AHI using a nasal mask and a full face mask on separate nights. And they found a mean CPAP pressure of about 12 centimeters of water, similar residual AHI between the 2 nights. And so, this was another piece of evidence, if you will, that, at first blush would seem to suggest, hey, a full face mask is just as effective as the nasal interface. The authors acknowledge in this study that it was not designed to absolutely eliminate the possibility that these patients could be treated with nasal CPAP. So, when we think about this, then, what do we know in terms of the literature at this point, in terms of what is the effect on airway obstruction are there differences in pressure requirements? And what do we know about patient preference? And so let's talk about the effects on airway obstruction. So this is a nice paper, which I kind of encourage people to pick up and read when they have time. It's published in the anesthesiology literature, but it's a nice paper in that it makes the case, most anesthesiologists will prefer to sort of do ventilation by a full face mask. But this paper makes the point in case that you can do successful ventilation of patients with the nasal interface if you take appropriate, precautions in terms of positioning of the airway. But, one of the things that they talk about here is, what the concerns were with the use of a full face mask and why it may be inadequate in terms of keeping a patent airway. And so there's a couple of hypotheses, people think about here. So one is that, you're laying in the supine position, and so you're pushing on the mandible where the lower part of the full face mask typically rests, and that's going to push the chin back further, and that's going to potentially narrow the posterior airspace. In addition, there could be displacement of the tongue and the soft palate because air that is pushed in through the oral cavity is going to push those soft tissue structures posteriorly and narrow the upper airway. It may encourage mouth opening. It's well known that if your mouth is open, that decreases the anatomic size of the airway, posterior airspace. And so that's going to increase the collapsibility of the airway. The other is that, when you're pushing air in through the nose, as well as through the mouth, if you think about what the effect is on the soft palate, the positioning of that palate may result in such a position that it's going to promote oronasal breathing, and you're not going to have an effective pressure that's across the airway that effectively opens it up, as opposed to if you were to solely deliver the airway pressure through the nose or through the mouth itself. So this is a study that just looks at, what the effect is of mouth opening on upper airway collapsibility. It's a small study, but what they do show is that when you have the mouth open, that the critical collapsing pressure is higher compared to when the mouth is closed. So just to remember, a more negative critical closing pressure means a less collapsible upper airway here. And this is a case report where this is a patient who had ALS, who had been admitted with progressive respiratory failure, and had a PCO2 of 68, although the pH was compensated and was started on bilevel ventilation, and then transitioned to a trilogy and underwent a sleep study. On night one, where they used an oronasal mask, you can see that the settings were 16 over 4 in ST mode. And you can see that the AHI was reported at about 34 episodes an hour. The transcutaneous CO2 rose up to 75 millimeters of mercury. On the second night, they ended up switching over to a nasal interface, and they found that the nasal pressures they required were much lower at about 12 over 4. And during this night, the AHI was normalized completely, and the transcutaneous CO2 levels were significantly lower compared to the first night. It's a little bit hard to see, I think, with the on here, but I'm going to just push play. But what the authors felt when they were examining the airway is that as air was being delivered into the mask, you can kind of see that when the mask pops off the face, that the tongue underneath the mask appears to be slightly being pushed backwards, if you will. And so, they're concerned that there was posterior displacement of soft tissues, and that was making it difficult for the full face mask to effectively ventilate this patient. This is a study, just another case study, where a patient was tested using a nasal mask and an oronasal mask. And they actually had an endoscope in the airway at the time during the titration. So this patient had a BMI that was only 26, had severe sleep apnea on the baseline study of 76 episodes an hour. And an oronasal mask was used in this patient due to reported oral breathing. And with a full face mask, this patient needed 16 centimeters of water, but even with that, the residual AHI was only cut in half to 32 episodes an hour. When they went to a nasal mask, only 7 centimeters was needed, and the AHI was less than 5. You know, when they examined the airway, you can see here that, you know, with the nasal interface, you know, the epiglottis is in a more favorable position, as well as the tongue base, and you can see that the airspace is much more patent in the case of the nasal mask compared to the displacement here with the oronasal mask. There have been some other studies sort of looking at, you know, what happens with oral breathing versus nasal breathing versus oronasal breathing. This is one study just looking at MRI during wakefulness and looking at what happens with the airspace at the retropalatal and retroglossal space. So, you know, what they did was they put patients on various pressure levels of CPAP through a nasal mask or through a full face mask. And they made measurements of the retropalatal and the retroglossal airspace as shown here. You know, and what they did was they came up with these measurements in terms of, you know, how large was the airspace at those levels. And so they looked at this with the nasal mask and the oronasal mask with the mouth closed and during nasal breathing. They then looked at it with mouth opening during oral breathing and mouth opening when the patient was voluntarily doing oronasal breathing. And you can see that, you know, when the patients were performing oral breathing or oronasal breathing, that the size of both the retropalatal and the retroglossal airspace, you know, no matter what the pressure setting level was much smaller cross-sectionally compared to, you know, when the mouth was closed and the patient was breathing through their nose through either of these interfaces. So indicating that, you know, when one is mouth breathing, that this does tend to narrow the posterior airspace. You know, the Brazil group has been very interested, you know, in this phenomena with, you know, looking at full face masks, and they've done a series, I think, of some elegant studies, just sort of, you know, thinking, you know, about what the effect is of these interfaces. And so I'm going to show you the first of a few studies from them. But this is one study that they performed in 18 patients, you know, overall severe sleep apnea, you know, class 1 obesity, middle aged. And what was nice about this these series of studies is that, you know, they used a CPAP mask that was partitioned into a nasal compartment and an oral compartment so that they were separated. And, you know, they had a valve so that they could go ahead and make sure that the patient's either breathing or the pressure was delivered exclusively through the nose, exclusively through the mouth, or was delivered both through the nose and the mouth. And what they could then do is look at both the route of breathing, you know, on either of these approaches and quantify this in terms of whether patients were predominant nasal breathers or oral breathers. And then they were able to obviously look at different things like, you know, the residual sleep apnea. And so what they did this over, they did induction of sleep using midazolam. And they would do nasal endoscopy because in these studies, they were also looking at the cross-sectional areas of the airway. And so in this particular study, 6 of the 18 patients that they studied, you know, had stable breathing on an oral nasal mask, whereas only 2 out of the 16 patients that were oral breathers were able to demonstrate stable breathing, if you will. If you look at these various panels, what you're seeing here basically is, you know, what was happening, you know, when they were at a stable level of flow limitation, or sorry, stable level of breathing. In patients that demonstrated, you know, predominant nasal breathing patterns, you'll see here basically that, you know, if you had more than 50% nasal breathing, you know, you had essentially a stable breathing. However, patients that had less than 50% nasal breathing, you will see that they tended to have more episodes of disordered breathing, whether they were hypopneas or apneas. So again, this notion that the route of your breathing may sort of predict whether you're going to have stable breathing or unstable breathing, if you will. In 2 of the patients, with oronasal breathing and 4 with oronasal masks, there were residual events seen even after they titrated patients up to a maximum of 20 centimeters of water. And so they were not able to fully treat those particular patients. When they looked at the airspace here, looking at the nasal versus oronasal breathing versus oral route, you can see sort of the differences here where the nasal route, you can see that the airspace looks much larger compared to the other 2 routes of breathing. When you look at this in aggregate across the patients that they studied, you can see that when you look at the distance between the epiglottis and the tongue base, that with nasal breathing, that this is much larger compared to if you're breathing, oronasally or orally. This is a follow-up study that they published in Chest of 2019. What they did in this case was to identify patients that had been, identified as requiring a full face mask because of the issue of presumed airway obstruction or congestion and mouth breathing. And these were patients who are chronic oronasal mask users. And they wanted to look again at the route of breathing effects. And so this was 13 patients, again, using their model of midazolam-induced sleep with the compartmentalized mask. And they did a series of 3 different things. One was to do a titration using the full face mask versus the nasal mask. They then went ahead and they lowered the pressure from the effective treatment pressure to just stable flow limitation to see what the effect was of a nasal interface versus an oral nasal interface. And then they did a 3rd step, which was to then during that period of time was just to tape up the mouth underneath the full face mask and see what happens when you're using a full face mask. And so this is one of the patients that they studied, out of the 13, but was also seen with other patients where you see that, even though pressure was increased, through a range of pressures over the course of the testing, they were unable to really effectively open up the airway. And this patient continued to have airway obstruction that occurred when they were using oronasal breathing with the oronasal mask. When they transitioned by, blocking off oral flow so that the patient could only breathe nasally, you can see that, they were now able to induce stable breathing pattern at a reasonable pressure at around 14 or 15 centimeters of water. When they then looked at the difference in CPAP pressures required, whether you're using a nasal interface versus an oronasal interface, you can see here on average that the effective pressure under the nasal interface was about 2 centimeters lower. Some patients were more dramatic. There were about 5 patients shown here with the solid circles where they were unable to effectively treat their obstructive sleep apnea despite getting a maximum pressure. And these patients continue to have persistent obstructive sleep apnea. In addition, when they looked at, the differential in pressure between the nasal and oronasal interfaces as a function of how much mouth breathing they were doing, they seem to see a correlation that with more mouth breathing, that the differential between the required pressures under both the interfaces was linearly associated. When they then went to the experiment where they added mouth tape, you'll see in the absence of a mouth tape that airflow was substantially lower when you were using the oronasal mask. But when you tape up the mouth under the oronasal mask, the airflow is similar as what you would see with the nasal mask because the patients are effectively having to breathe through their nose. It also shows that these patients that were, supposed mouth breathers and had to use an oronasal mask indeed could breathe through their mouth during this period of sleep. And you can also see that airway resistance, which is higher, under the full face mask condition. Once you tape up the mouth, the airway resistance is similar once they're forced to breathe through their nose. This slide just shows you a tracing that, while you have a nasal mask interface, that, airflow is mostly maximal under this setting. And then once the patient is transitioned over to oronasal breathing, that airflow actually gets smaller, and there's the development of more obvious flow limitation that's occurring here. And so this again sort of suggesting that there's a reduction in the airspace and an increase in airway resistance. And when they made these measurements across a group of these people, what they showed is that when you go from the nasal to oronasal mask, or vice versa, if you start with an oronasal and you go to the nasal mask, there's increases in upper airway resistance when you're using an oronasal mask, and there's a reduction in airspace size with the oronasal mask compared to the nasal mask interface. Yeah, Kingman, you got a question?
Yeah, and in this example, which is a continuous tracing, it looks like, the mask position is unchanged, but there's a little flap or something that closes off the oral.
That's right. So in the first case, right, the oral part is closed off and they're exclusively bleeding through the oral nasal route. And then they basically open up that flap so the patient could breathe through the nose and the mouth, depending on what they wanted to do.
So how do you think that, there's a change in position, a change in sensation, a change in what,
Yeah.
I mean, it's immediate. It's really immediate. I would have thought that there would be some at least mechanical, transition.
Yeah. Yeah, I think, they're a little bit high with respect to the level here that they're looking at.
Right.
The first part, you can see the epiglottis. The second half, I can't quite see the epiglottis in the second half here. But I would postulate this probably has more to do with sort of, positioning of the palate, if you will, right? As soon as you flip off that valve. And really now, if air is going both through the nose and through the mouth, you've got, the tongue and the soft palate potentially being pushed back somewhat slightly, and that's going to start to narrow the airspace and increase the resistance.
That's exactly it. It's the soft palate has raised up, and so that's going to be reducing, like it's movement of the soft palate to create this oronasal breathing.
There's a nice, I don't have it here, but Shiro Isono from Japan has done some of these studies under, anesthesia that he's known for. And, he's sort of postulated about this sort of, ball valve effect, if you will, which you sort of don't get an effective opening of the airway, when you're using this, using the oronasal interface.
Okay, thank you.
So, this is a study, it was just published as a letter, but they actually brought these patients back a few years later. And they did another component in terms of just asking these patients who are chronic oronasal mask users, what do they actually breathe through, when they're asleep and awake? Is anybody sort of just looked at what's the spontaneous breathing route in these patients? And so, what they did was, when they looked at these patients, was they characterized them as predominantly nasal breathers, oral breathers, or oronasal breathers. And you can see these are, the 13th patient, they didn't get usable data, but of the 12 patients that they had, the majority were mostly nasal breathers. Only one of the patients was truly an oral breather. Some of the patients did have a little bit of a mix of oronasal, oral, and nasal breathing, but I think this study goes to show that we don't actually do a very good job in terms of knowing whether patients actually end up breathing through their nose or not when they're sleeping or not. We just make assumptions. And what they did, they looked at this in different ways. They looked at it, is there a difference in breathing out when the patients are awake or asleep, which is this upper left-hand panel. They saw no differences. They looked at differences in breathing route between non-REM and REM sleep, really saw no differences here within patients. They looked at position, lateral versus supine, and they didn't see any significant difference here in the patients that they looked at. And so I think this is an interesting study, just published as a letter in the Blue Journal in the last month or two. In terms of thinking about, Kingman, going to your question about mechanisms, again, one of the mechanisms, probably more so with some of the older full face masks or the traditional full face mask, right, is the full face mask sort of pushing the chin backwards? Could we potentially stabilize that by using a oral appliance here? And so this is a study done by Marta Kaminsky, up in Montreal, where they just looked at a case series of 6 patients, and they looked at the effective required pressure under nasal masks versus oronasal masks. And without the mandibular advancement device under the nasal interfaces, you can see that the pressures required were quite comparable, 10 versus 11 centimeters. When they transition these patients over to oronasal mask or full face mask, you'll notice that suddenly about 4 of these patients, they had difficulties identifying an effective CPAP pressure when they were using this, and then in about 3 of these patients, when they added the mandibular advancement devices, they were able to lower the effective pressure, or find an effective pressure that could treat their sleep apnea. Still higher than with a nasal interface only. But the mandibular advancement device seemed to sort of temporize and lower the pressure requirement. So are there actual differences in the pressure requirements? And so, and what's the effect on the AHI? So a couple of studies just to show you. So this is published in Sleep in 2011. And what you're seeing here is just a number of patients on the y-axis, and on the x-axis is the difference between using a nasal interface versus an nasal interface. And you can see that, one is that under a full face mask, that the residual RDI does tend to be elevated compared to the nasal interface. And what's typically found is that there's a larger pressure differential for a given patient when you're trying to look at the difference between a nasal interface and a full face mask. So you can see sometimes that differential could be as much as 7 centimeters in one patient here. This is another study done by Matthew Eben in Germany, just looking at the oronasal masks and, demonstrating that it seems to result in a higher pressure requirement in those with severe sleep apnea. So what you're seeing is tertiles of sleep apnea severity. So the mildest patients here versus the highest or most severe patients on the far right. And you're looking at the different differential pressure, i.e. the full face minus the nasal mask pressure. And you can see here, depending on the combination, this first one is looking at a nasal pillow versus a nasal mask, where you see that the pressure differential is about 2 centimeters. When you look at oronasal versus nasal, the mean difference was about 7 centimeters of water. And when you look at an oronasal versus nasal pillows, the differential was about 4 centimeters. So really, again, when you're comparing the oronasal mask to either of the nasal interfaces, that's where you get the largest differential in patients with severe sleep apnea. This is another study where it was a randomized crossover study. And they randomized patients to titration either to first to full face mask or first to nasal mask. Patients were on the prescribed pressure using that interface for 3 weeks, and then they were crossed over to the other interface for an additional 3 weeks. What they found was they had more dropouts in people that were randomized to the full face mask group to begin with. Although, interestingly, there was 34 minutes of PAP use in the full face mask group compared to the nasal mask group. What you see here in the figures here is that, for those that initially started with a nasal mask and then transitioned to a full face mask, the squares show their baseline AHIs, which are somewhere between 20 to 60 episodes an hour. And then the circles are the residual on the nasal mask, and the diamonds are the residual on the nasal interface. And you can see almost uniformly on the oronasal mask, the residual AHI is higher than what you see with the nasal interface. If you used an oronasal mask first, before you were crossed over to the nasal mask, you see, a somewhat similar finding, although not quite as robust, with only 2 of these patients here that demonstrated persistent elevations. Other thing is that, what's also just, seen is just, in terms of lab behavior. This is a study published in Australia where, they just looked at happening in our labs and, what predicts, when patients are going to be given a full face mask versus a nasal mask. And what they tended to find is that, patients that have a higher positive airway pressure requirement tend to be given a full face mask more often. So this is a series of about 350 CPAP titration studies. About half where they used a full face mask. These were patients with severe sleep apnea. What they found in the aggregate is that the mask pressure differentials were about the same. You could say maybe there's a 2 centimeter difference with the oronasal mask versus the nasal mask, but probably not statistically. The residual AHI on the oronasal mask again tends to be higher, and these are again across different places, different labs. This is about the difference that you're seeing here. And what they found was that when they just looked at the subset of patients where patients had a requirement of 15 centimeters or higher, there tended to be a prescription more for using the oronasal mask. So this probably speaks more to just sort of our inherent biases, that when patients are going to be on higher pressures, that we tend to think for one reason or another that a full face interface is going to be more appropriate for those patients. This is a study done using the French database. So one of the nice things about the French is that they have the ability to actually look at the prescription of CPAP quite robustly in their population. And this was a study that they did in 2013 of about 2,000 patients, with a follow-up visit over a period of 2 years after diagnosis of a sleep apnea. And they looked at different things in terms of, based on the type of mask you were prescribed, whether it was a nasal mask, oronasal, or a nasal pillow, they looked at what was the differences in adherence. And if you look at the bottom left-hand panel here, you'll see that those that were on an oronasal mask tended to have lower adherence compared to nasal masks or nasal pillows. When they looked at the pressure requirement in the aggregate, use of a full face mask tended to be associated with a higher pressure requirement than the use of the other 2 interfaces. Interestingly, there was a greater degree of complaints of a dry mouth or choking sensation with the use of a full face mask compared to the nasal interfaces, and there was more complaints of psychological inconvenience with the use of the full face mask as well here. Some of this, of course, may speak to selection biases, of course, in terms of, maybe this is the population of patients that get put on an oral nasal mask may be special, and maybe it's confounding by indication, if you will. But it is sort of interesting when you look at this data, in complementing the other data that I've shown you so far. So what do we know about patient preference? So there hasn't been very many studies looking at this, but this is one study that was done in the late 90s, where it was a randomized controlled trial of full face mask versus nasal mask. 20 patients were enrolled. Adherence was higher in those with a nasal mask by about 1 hour compared to those with the full face mask. The Epworth was also better in those patients that used a nasal mask versus a full face mask. There were improvements in dry mouth at the expense of more air leaks and claustrophobia, though with the full face mask. At the end of the day, patients were asked, what their preference were, and really only 1 in the 20 ended up preferring the full face mask in this particular study. In another study, Prossi and Berry that I've already talked a little bit about, when they looked at sort of patient acceptance, 6 out of the 10 patients, wanted to continue with nasal CPAP compared to a full face mask. In another study done in 2000, 2 of 17 patients that were offered a full face mask because of the issues of nasal resistant mouth leak ended up using it over the long term, but the remainder were managed successfully with the use of nasal CPAP and heated humidification. in the Teo study that I showed you, which is shown on the right-hand side in this picture diagram, they studied 24 patients, again, that had the ability to use both of the interfaces. It was only after a single night, but 19 out of the 24 patients preferred the nasal mask interface over the full face mask interface. So there is a tendency more for patients over the long term to prefer that. This notion of it, choosing a full face versus a nasal interface, this has now come into our PAP guidelines, is in the special consideration section when it was published. When we looked at these data, we performed meta-analyses in terms of looking at adherence differentials. And again, the literature seems to show that when you look at adherence, generally nasal PAP is associated with greater adherence compared to oral nasal interfaces. And in addition, the studies that we tended to see that there were fewer side effects with the nasal interfaces compared to the oral or oronasal interfaces. And so, based on this, the guideline committee had ended up suggesting that with routine initiation of PAP therapy, clinicians usually should use nasal interfaces over oronasal or oral interfaces. So just coming back to our patient that I was taking care of, I just said, it's been a while, it's been more than 10 years, we should go ahead and do a retitration, if you will. And we ended up doing a split night study, because one, I wanted to confirm, does he really have sleep apnea as bad as we think he did from the original studies? This is a 1.5 hour part of the night. He ended up having severe sleep apnea at 57 events per hour. He was then transitioned over to a titration study. The instructions were to only use a nasal interface on this particular night. And you can see here during the titration, they went from a range of 4 to 8. And you can see in terms of the total RDI that, even at 6, he probably was reasonably treated. Yes, there was briefly an increase at 13.8, but it went back down at 8. So somewhere a pressure of 6 to 8 probably ended up being effective. And so, in this patient's case, we ended up transitioning him over to CPAP of 8 centimeters of water. After about a month, he came back. His wife was like, "Oh my gosh, she looks day and night difference. I can have a conversation with him in the middle of the day. He's not falling asleep. Meanwhile, I'm trying to talk to him. There have been some improvements in his short-term memory. So they ended up being very happy, and he's actually been 100% compliant with using his CPAP ever since. And so, in summary, patients with full face mask, it's not that full face mask is always bad, but I think people should be aware that it can actually induce partial airway obstruction. In addition to that, because it's inducing partial upper airway obstruction in some patients, this is going to result in incomplete treatment of the AHI, and then may make us or even a technician think we have to go to something like bilevel therapy when it's really more about the mask interface than anything else. The pressure requirements are going to be higher. And so while in the single patient, it may be no big deal if the pressure requirement is higher, it does on average probably lead to more pressure intolerance, and then that can play into issues of just long-term adherence. They're just not going to be as generally preferred by patients because of the issues of claustrophobia. And, full face mask, they often have mask leak issues, particularly in men that are going to have facial hair, for instance, and don't want to get rid of their facial hair. And so I think an important pearl is really that full face mask should not be assumed to be interchangeable with nasal mask. And you really do have to monitor the patients and look at the different pieces of evidence in front of you, including CPAP downloads. So the approach I tend to kind of recommend, is particularly during titration studies, nasal interfaces should be first line, even if patients report they are a mouth breather, at least to start. Right? I mean, a lot of times the reason they're mouth breathing in the first place is because they have sleep apnea, and that's what they're used to seeing. they don't know how they breathe once you actually open up their airway. And that's what we're doing with the CPAP titration. And so often mouth breathing will improve, once you start treatment for sleep apnea. In addition, they're getting heated humidification once they're started on CPAP, and that can improve nasal congestion and turn them more into nasal breathers. There's a reason we want to breathe through our nose, and we want to maintain that as much as we can. For PAP setups, again, if you're going straight to auto CPAP, really assess tolerance with nasal interfaces. For patients that report difficulties breathing with a nasal interface, don't just give up and say, okay, we're just going to go to an oronasal mask. Identify the problem and address it. And so, look at the use of heated humidification to decrease nasal resistance and convert that patient from a mouth breather into a nasal breather. If it's discomfort with the EPAP, look at expiratory pressure relief, or if you need to, you could think about BiLo. Nasal congestion rhinorrhea, address that using all the tools that we have at our disposal. And in some cases, nasal surgery may actually be beneficial in a small subset of population. If an oronasal mask has to be used, make sure you have a good fitting. And this can be difficult, based on the published literature and just, anecdotal experience. But most importantly, again, don't just assume it's going to work. Verify the effectiveness in a few weeks using CPAP adherence data and complementing it with, a bed partner's observations of snoring. I've picked up, cases where, the bed partner said, oh, now he's starting to snore more since we switched over to the full face mask. And so they kind of say, that led me to look at the CPAP adherence data and then say, maybe it's the mask that's causing this issue. So I'm going to go ahead and stop there and happy to take any questions.